Welcome from CVI2017. I'm Dr. Michael Luna here with Dr. Madhan Sundaram from the University of Arizona College of Medicine, who'll be talking about a tale of two osteoarthritis CTOs.
Thank you. First of all, I just want to thank the organizing committee of the CVI 2017, more specifically Dr. Banerjee and Dr. Berlikus for the kind invitation. I'm Madhan Sundaram. I'm one of the faculty interventional cardiologist at University of Arizona College of Medicine, but mostly working out of the Southern Arizona Veterans Healthcare System in Tucson, Arizona. Let's just jump right into the case. I want to show a couple osteoarthritis coronary chronic total occlusions that I did recently. I do not have any disclosures pertinent to this presentation. So this first gentleman is a 70-year-old veteran with class 3 angina who was referred for an angiogram due to persistent angina. But off note, he's had an angiogram 2 years ago that shows a chronic total occlusion of his RCA with good collateral from the LAD. So he was opted to be treated medically back then, but now he notes clear progressive angina and exertional dyspnea. So at this point, we did not do a non-invasive imaging because we knew the lay of the land. But and he also has, just like all the other veterans, he had non-limiting bilateral intermittent claudication. So this is his past medical history, nothing fascinating: severe COPD, hypertension, hyperlipidemia, which is the reason why he was not referred for bypass, ex-smoker but currently quit. And his medications, as you can see, he's on 2 antianginals. He did not tolerate a higher dose of metoprolol per reports, and he also had bad headaches with nitrate, so he's still on the lower dose, but otherwise adequately optimized. So this is his angiogram. So again, since we knew the lay of the land, this was a planned CTO intervention. As you can see, 2 guides from bilateral femoral, 8 French, AL 0.75 for the RCA, and an EBU 375 for the left for the dual injection. And you can clearly see the stump of the RCA occlusion, greater than 20 millimeter occlusion, no obvious septal collaterals. You know, again, this picture does not do justice, but we looked for obvious septal collaterals. We did not see, although there were epicardial collaterals, which I wanted to stay out of, a conscious decision. Being fresh out of training, I didn't want to venture into the epicardial collaterals. So the decision making here, osteocclusion, we know that antegrade wire escalation is not going to work well, so I wanted to still follow the hybrid algorithm, just try briefly, but then proceed with septal surfing, retrograde wiring via the LAD collaterals. Again, we had to surf because there was no clear angiographic collaterals. And if successful, we wanted to do either a reverse cart or a cart and wire externalization. So here is our antegrade wire on the left side of the screen. You can clearly see that antegrade wire is not in the vessel lumen. It's clearly outside, but we left that there. We came from the retrograde, the septal collaterals. We were able to penetrate through the distal cap, but we were subintimal, both fronts. So here we performed, we performed CART, not reverse CART. Apologize for the misdiagnosis there, but we performed CART. So we inflated a balloon from the antegrade guide, and we used a pilot 200 to re-enter from the retrograde wire, and we used an 8 French guideliner through which we advanced the retrograde wire, and the wire was externalized. So the antegrade wire was Fielder XT, which was placed in the subintimal space. Retrograde wire was pilot 50, which was eventually escalated to a pilot 200. And we used Corsair microcatheters and Viper wire with a Viper glide for wire externalization. And after that, it was pretty standard routine procedure.
So during that CART procedure, your balloon was on the antegrade wire?
On the antegrade wire, not on the retrograde.
That, just so we're clear, that is actually the reverse CART.
Reverse CART.
It's reverse
that's
CART,
right, yeah.
exactly.
We used a 2020 balloon, and then followed by stenting. We used a 27538 and 22523, and the osteal RCA, since it was clearly involved, we used a 3023 drug-eluting stent. And this would be the final result on that. So this is proceeding on to the second case. Again, I wanted to show 2 cases because both of them had similar looking angiograms, and both patients were done on the same day. We have a dedicated CTO day, so we try to do most of the CTOs the same day. So here is a 58-year-old gentleman, had both carotid and peripheral vascular disease. He was referred for persistent angina and worsening LV dysfunction. He's had multiple prior endovascular peripheral procedures, and off note, he had a symptomatic carotid stenting, or TIA, 2 months ago, and underwent a left internal carotid artery stent, and the right side is chronically occluded. So he's clearly high risk, and this is his anatomy here. So well collateralized RCA, and again, an osteal occlusion. He did have some bridging collaterals, antegrade fashion, but mostly he had very good interventional septal collaterals. So in this case, our plan was to actually go retrograde, but also, again, following the hybrid algorithm, we wanted to try briefly the antegrade wire escalation strategy. So here we were fortunate enough to actually cross antegrade with a pilot. We eventually, started out with the Fielder XT, but eventually to a pilot 200 wire. And as you can see, we wired on fluoroscopic images and cine to make sure that the wire was going true lumen. We were able to get into the RV marginal, which really confirmed that we were true. And after that was pretty standard ballooning and stenting. Corsair microcatheter, initially tried with Fielder XT, but eventually crossed with the 200. Ballooned with a 1520 apex push, followed by stenting. We used 2 long stents, Zion's 2538 and a 2523, and the ostium was completed with a 27515 with osteal flaring. And I guess that was the final result right there. So that was the final result. So pretty major RCA. He does have an osteal left circumflex lesion, truly osteal, with no significant disease in the LAD, so there's no easy percutaneous way of fixing that, so we elected to treat that medically. So both patients with osteal RCA occlusions, the approach was different and was based clearly on the anatomy, but it's important to follow the hybrid algorithm for the CTO revascularization, and you have to be proficient with both antegrade and retrograde techniques to tackle these challenging cases. Thank you.
Absolutely, yeah. Great cases, both of them. A couple of questions for you. When you see, you're right, the right coronary osteal occlusions are the challenging ones for sure. What about that, the characteristic of that occlusion leads you to not even try an antegrade approach and primarily do a retrograde approach?
If it's really true flush occluded ostium where you can't even get a good antegrade wire to sit in the vessel, then there's no point trying antegrade, I think, because one, you have to have a microcatheter, a good guide to start pushing, otherwise your guide's going to just buckle out. So I think if you have one of those situations where you can't even get a guide to sit into the ostium, then that's clearly an indication to go retrograde. I think that's one of the things.
Absolutely, and your second case, I think, points out the what we tout a lot in our field of CTO PCI, and that is give antegrade a go. Give it a go, give it a shot. But an important point to make also is how long you attempt the antegrade approach in that situation. So how long do you normally do
So
that?
I think if you have good septal interventional collateral, so to speak, the interventional collateral. So if you had good interventional collaterals and you are very comfortable doing retrograde approaches, then ideally you shouldn't spend more than maybe 10 minutes going antegrade. And if you're not getting anywhere, and if you clearly got subintimal, leave the wire subintimal, antegrade, and then try retrograde to do reverse card.
Yeah. Great points, great cases. Thank you so much.
Thank you.